This is a Defocus Media production. What's up, everyone? It's your favorite optometrist, Dr. Daryl Glovin.
And I'm Dr. Jennifer Lyerly, resident optometry nerd.
And welcome to Defocus Media, optometry's #1 podcast, where we discuss the hottest topics, latest technology, eyewear, practice management, and more. So sit back, relax, and defocus.
It's a new episode of the Defocus Media podcast. I'm Dr. Jennifer Lyerly, and I'm here with podcast veteran and previous Defocus Media guest, Dr. Derek Cunningham. Welcome back. How have you been?
Great. Good to be here.
Well, I am so excited to have your perspective on because you work at a refractive surgery clinic. Would you mind sharing with our guests a little bit about your specific role in optometry and the kind of patients that you're seeing?
Sure. We have a little bit of a specialty clinic. We're a referral only clinic. So you have to kind of be sent by an MD or an OD, mostly ODs, to our center. And what we specialize in is refractive options. So, really getting people to be able to see every part of their life without prosthetics like glasses and contacts, and also to get around basically anatomical issues and disease issues and aging issues that we'll all run into. And so, we do provide solutions for keratoconus and cataracts and corneal disease and some retinal diseases. So really in a practice like ours, we specialize in maximizing vision, and that plays into a lot of what I do in my other practice with sports vision as well. So they marry very, very well. So that's primarily what we do, is provide solutions for people to see better than what they're, currently doing.
I mean, I think no explanation needed past what you just gave about why a presbyopia eye drop might be an interest in your practice. We all know as optometrists that refractive surgery, people's eyes keep changing. Birthdays happen. Their refractive outcomes might be absolutely excellent, but of course, there's still going to be changes in their life that are going to have new needs. And so it makes perfect sense that trying to provide an option for them to maximize that vision that doesn't have them going back into glasses or contact lenses would really fit a need for your patients. What's been your experience with offering a presbyopia drop to a patient?
Well, it's been a little bit of a wild ride. Like anything in its infancy, there's trials and tribulations. And I think we all saw that, there was an initial attempt that I think it had a great concept, but it just wasn't well refined. And so we saw several years ago, there was a drop that was available. I, like most other practices, probably was maybe a little too gun-ho, and I lined up probably 100 people right off the bat. So, the day it was available, we prescribed it to all 100. And I'll never do that again. I got so much blowback. I got so many complaints, mostly because I think there was a disconnect between what we thought would happen and what really did happen. And that shouldn't be surprising. When it comes to a lot of, especially in this case, when it comes to a lot of products that rely on neural adaptation and neural modulation, there's going to be varying degrees of success regardless of the similarities between your patients. So, unlike, let's say, something like, and I'll put it to this way, things like spectacles and contact lenses, they are very defined in how they change the optical pathway. But not everyone responds the exact same way. You'll fit someone with a multifocal eye or contact lens, and they'll say, "Oh my gosh, this is amazing." You fit your next plano presbyope with the multifocal contact lens, and they say, "This sucks. I can't see anything." There's some degree to that no matter what you do when you change vision. So with the drops, we had to find our way through that. So one of the things that we covered was basically this idea that when we came to learning more and more about how presbyopia drops work, is adjusting expectations. All right. And that's one of the things, even when we do surgery, we say, whenever we're going to get rid of glasses and contacts, we're going to minimize your need for them. I think that's a big key. The second thing is understanding, where they're going to be more beneficial and where they're going to have limitations. And I think discussing that with patients is good as well. A lot of people naturally assume, maybe in a primary eye care clinic, that they're not going to be the practitioners aren't necessarily going to want to jump on this concept of presbyopia drops because they want to sell glasses and contacts. It's the same thing in a practice like ours. Everyone just assumes because we want to do surgery, we're not going to embrace this whole idea of presbyopia, correcting drops, and it's the exact opposite. I will tell you that we probably more than anyone else love the concept of being able to provide any resource possible to enhance our patients' quality of life. And that's what we want patients to think of us as.
Absolutely. I know similarly, when 1.25% pilocarpine came out, I was also kind of really excited, really hopeful that this drop would be a game changer and not prescribing in a way that we know now would work. We were doing an in-office sample and expecting people to see with one drop that same day, 20 minutes later, and that's just not how it works. So thank goodness a lot of learning happened between that launch and the launch of Qlosi at 0.4% pilocarpine. And now we know about the setup for success with using the drop and then 2 to 3 hours later using the second drop and giving it that full 1 to 2 weeks for neuroadaptation and educating what to expect with vision. And it has led to much better success, it sounds like, in your patients and patients across America.
Yeah, I would say...
Oh, go ahead. I was going to say, walk me through what you tell a patient to set them up for success.
That's exactly where I was going, is the concept that, one of the things that I think practitioners shouldn't be scared about is this idea that this is a performance-based product. So you have no idea if the patients are going to like it until they try it. There's limitations, and there's some people that aren't good candidates. We'll talk about that in a second. But literally, I will have a plano presbyope come in with the kind of same situation, back-to-back 2 plano presbyopes, and one will absolutely love this and one won't like this. And that's not for me to decide ahead of time with my crystal ball who's going to like it or not. It's for the patient to decide, and so we certainly want to make this available to all. We want to make sure everyone knows this is available. It pains me, and I don't want this to happen to my patients ever, but it happens a lot to the patients that are referred to us. When we provide options for vision correction, they say, well, why didn't anyone ever tell me this before? Why didn't, my last doctor, my last ophthalmologist, my last doctor tell me that this was an option? Or, I had LASIK, I had lens exchange a little while ago. Is there anything else I can do to help? And so making sure people are aware of this is number one. But number two, I just let everybody know who's looking to enhance their vision, whether in any way possible, that there's options. There's glasses, there's contacts, there's surgery, and there's drops. And really, we let everyone know that right from the bat. And the drops are now a consistent part of the conversation, especially obviously with presbyopes. And then the second thing is just saying, listen, these drops will afford you ability to lessen your dependence on glasses or contacts. And that's basically the way I put it. I don't say it's going to get you out of glasses or contacts. You're still going to need those when you're doing detailed work or long periods of near work. This is going to give you an opportunity to not need them certain times of the day. And for most people, it works, but some people it doesn't. Do you want to try it? And that's basically what it comes down to.
That sounds fantastic. Well, I know. So one of the concerns, we mentioned that doctors might be having is because of that experience they had with 1.25% pilocarpine and not really understanding how a pilocarpine drop for presbyopia would work. We've got that covered now, how to have the right prescribing and how to have the right expectation setting. I think the other big concern that doctors might have when thinking about prescribing a drop for presbyopia is, oh my gosh, am I going to have a retinal detachment? And there have been studies looking at the percentages of this. So let's talk a little bit about that data and kind of assuage any sort of fears that a prescribing doctor might have. Back in 2024, we know that the 1.25% pilocarpine for presbyopia use was associated with a 3 times higher risk of retinal detachment versus artificial tears, but that risk was still really low at 0.78%. But that's still a risk. Now we're talking about with Qlosi, a much lower concentration of pilocarpine, but let's talk a little bit about what we need to be aware of as doctors when we're thinking about the right patient candidate.
The people that are predisposed to retinal detachments are predisposed to retinal detachments. That's what they are. I can tell you that through years and years and years, I'm older than you, back in the day using pilocarpine for glaucoma, I never once checked someone if they were going to detach before I gave pilocarpine for glaucoma. I just gave it for glaucoma. But now that we're in probably what we consider more of a elective type situation with pilocarpine, I do think it warrants a peripheral retinal exam, as is stated in the package inserts of all of the myotics that are going to come out. You want to do a peripheral retinal exam to make sure that there's no increased risk factors. But I can say from a public health standpoint, something that's more important is just understanding likelihood of retinal detachments and who's going to get them. There is a potential that everyone can get one, and I do bring that up with patients. I say it's very small, but the people at significant risk of retinal detachments are your high myopes. High myopes, whether they had LASIK or not, are still high myopes, or refractive lens exchange or not, are still high myopes as far as how long their eyeballs are. Those are the people that are at risk. So those are the people that I exclude. And I just don't give them an opportunity. Not yet, not until we have better data. So these are people with really, really thin retinas. I don't think it's worth it. But that's, such an incredibly small percentage of the population. And the second thing is, yes, the data is somewhat nebulous, but the detachment rate was not what we'd consider highly significant. It was very small. As a matter of fact, in none of the presbyopia drop studies have we seen any detachments. These are all things that were seen clinically afterwards. And it's hard to draw a line on, were these people that were going to detach anyway that just so happened to use the drop? Right. So again, I still think it's a great public health thing, and it's good medicine to look in the peripheral retina just to make sure, everything's fine. Don't prescribe it to super high myopes. And the concentration, as you touched on in the end, is one big thing. This is the lowest concentration of POW that we've seen clinically studied, number one. So it is a big step away from a significant contraction of the ciliary body. And then the second thing, it's the lowest concentration of any of the miotics that we've seen come into the market. So it also plays into a very unique space. And in my case, I feel a little bit more confidence prescribing it because of that.
I think, we're 6 months in to Qlosi's availability and no reported retinal detachments. I think one of that is doctors are more aware and are not prescribing it in theory to a high myope or someone with lattice or a retinal hole that would be at risk, because they are aware of what happened with 1.25% and the low risk associated there. But also that low concentration of pilocarpine does appear to be, potentially no retinal detachments in any of the clinical studies for this drop to be approved, and 6 months in, no reported retinal detachments. So that's very reassuring. One other kind of call out about, when you look at who prescribed 1.25% pilocarpine Vuity, 7 out of 10 prescribers were not eye doctors. So these were prescribed by doctors who were not doing an eye evaluation at all, much less a peripheral retinal evaluation.
Yeah, that was crazy. And as a matter of fact, all the high prescribers, all the people that really prescribed high amounts of it were non-eye doctors, number one. And number two, this was all over Good Morning America. It was projected to the masses. It wasn't uniquely, set for eye doctors. Whereas, right. You see, we've learned our lesson. Qlosi, especially, is uniquely going after primary optometry, the people who kind of control the gates of vision. And again, it's a great product for ophthalmologists as well. But we think that optometrists are going to be the ones who are prescribing the bulk of these drops, and they're the ones that are getting probably the most education and the most familiarity with this drug as well these days.
I do think it's a really impressive feat. The specialty pharmacy that you would prescribe Qlosi through right now, it is specific to eye care providers writing prescriptions. If you're not an eye care provider, you don't have access to writing this prescription. So that's also, I think, really helping ensure that the patients that are getting these prescriptions have had a peripheral retinal evaluation, and we feel confident that they've got the right safety profile. So a lot of things, again, learned through failures the first time around, and now we've got something that's really a process that's going right, and no adverse patient outcomes as far as retinal detachment to report so far. So really, really incredible. Let's talk a little bit about what side effects are possible and what we do need to talk to our patients about with potential side effects with this drop. What did the study data share about what patients would experience potentially after using Qlosi?
Well, the studies are interesting because sometimes the studies show a little bit different numbers than we see in real life. And it's a lot of it's posed on how you ask the questions or how deep you dig in a study. In this case, roughly about 6.8, I believe was the number percent of patients really got a mild frontal headache upon initial installation that tend to alleviate with time, especially with repeated dosage or repeated usage. Because pilocarpine itself is a little bit of it has a mechanism that in the eye that you can't really get away from, that is associated with a little bit of burn as well. There was this, probably about 6%, 5.8% of people also reported that they had some installation site burning. All right. And these are relatively small numbers, but I found that the headache thing was interesting because the more and more I prescribe Qlosi, the less and less people will mention the headache, especially if I mention ahead of time. You might get a really mild frontal headache the first couple times you use it. I can say that maybe if you mention it up front, people don't seem to say they get them as much as you would expect. The burning, yeah, is some people. Remember, some people will say saline burns like crazy every time they put it in their eyes.
I
So
mean, yeah, absolutely. Every wedding drop,
yeah,
we might get a small percent of people saying it burns. So I think, with any eye drop, we're used to saying, hey, it might burn when you put it in, right?
yeah,
The
and the
burning
burning
was
obviously
very
goes away.
transient, very quick to resolve. We're not talking about a lasting burn here with this drop.
They didn't want to use it anymore based on what they were experiencing. Again, that's in line with almost any pharmaceutical medication we've ever seen.
I mean, it's just really exciting where you see such a low concentration of pilocarpine.
That
Or
wasn't fun.
concentration tracks.
Yeah, that wasn't fun dealing with all those phone calls. Nothing like that so far with Qlosi. I'll tell you that much.
That's great. All right. Well, moment of truth. Let's
Yeah.
talk about vision. What are your patients experiencing when it comes to their near visual improvement?
So two critical things to understand about when you modulate the pupil. When you modulate the pupil, basically the first thing is the brain is going to struggle with what it's seeing because it's used to a different pupil size for what it thinks it should have for the distance that it's looking at, even if you are presbyope. So pupil modulation does take some neural adaptation. And so one of the things that you'll see is that if patients can use this product for at least 8 days, they tend to have a much better success rate afterwards. And then they can use it at will afterwards, basically saying that if you can commit to using this for 8 days, we feel like you have a much higher chance of adapting to to be able to appreciate the effects of the pupil modulation. And the second thing is you really need the 8 days for your brain to understand what it's seeing. And at that point, it knows what to expect and it tends to get much better. The other thing too is I don't spend any time with a reading card. I don't care about a reading card. I really don't, because all that matters is does the patient like it or not. So when I prescribe it, I tell people I'd love for you to be able to read, roughly what's on a driver's license, 2040-ish. And that would be my goal. And for you to feel comfortable on your phone and your computer. Do I expect you to, and everyone's going to grab the pill bottle and read the backside of the pill bottle. Everyone's going to do it, right? And so you just say, I don't expect you to be able to read that. And if you set that expectation, I think people have a much higher success rate. They come back and say, yeah, that was awesome. I thought this was great. What we learned with previous presbyopes is if you said this will help you read up close, the first thing people did is literally put a drop in. And then a couple hours later, they were trying to read the back of a lottery ticket, like stuff that no one should humanly be able to read. And since they couldn't do it, they thought it was a failure. This is to make you more active. This is to give you more freedom in your life. And if people understand that, they love it. And some don't. And that's based on their brain, not you as a physician, not figuring out if they were a good patient or not. Some brains don't like it. Most do. So offer it and see if people want it.
When you look at the data on it, 8 in 10 patients are achieving 20/40 vision at near or better, which very functional vision when you look at that reading card. I mean, and again, I love a cell phone. I love to use a cell phone as a judge.
Right.
Most people that are at this time in their life have made their font a little bit larger anyway.
Sure.
So why give them a teeny tiny reading card with small font? They're not looking at font that small. Functional
But again,
vision.
you don't have to sit there and argue with them either, because I have plenty of. So in the study we saw, 2 people would come in and they would read the exact same, right? So they would read, 20/40 up close. And one would say, oh my gosh, this is awesome. And the other would say, it's not that good.
Not very good.
And if it's not that good, fine. They're not a good candidate. Move on. Yeah, you know what I'm saying? And so it's the idea before that we were going to prescribe a miotic and then have them come back to the clinic and try to convince them that it was doing better than they thought it should. No. People will tell us if it works, and if it works, it works.
We're not giving them back a 10-year-old eyeball. Their focusing system is not adjusting any better than it once was. We're creating a brand new pathway for vision, and that takes some time. So a single drop in office that you're sampling is going to do nothing other than make people think it won't work. So that's really explains if a patient is asking like, well, can I try a sample? I'm like, well, it's not going to work with a one-time dose. And that's an easy explanation for that. Well, I just a lot of food for thought as doctors are thinking about this going forward. If there is every time where patients are getting, drops, just know they need to be motivated and committed to using it for, I would just kind of throw it out there, a good 2 weeks,
Yeah.
8 to 10 days, something of that
Mhm.
nature,
Yeah.
to give their brain a chance. If they can't be motivated and committed to use it all those days in a row, they're not going to probably achieve success. So that's just a good pearl to take away from this. Let's talk about what our peers as fellow eye care doctors should be doing to set themselves up tomorrow in clinic to introduce presbyopia drops as a real viable way for their patients to have better vision, better outcomes, like integrated into their office.
Yeah, for me, the number one is the idea of don't be scared to offer this to patients. You're not picking and choosing who's going to like this. The patient's going to pick and choose who likes this. And the second thing is, don't be that practice that, they eventually go down the road a year or two later and they say, why wasn't this ever offered to me? Or why did I see this on TV and my doctor never brought this up? Simply bring it up. Again, stay away from your high myopes. Make sure you have some type of documentation of a peripheral retinal exam, whether that's digital or manual. And then, like I said, from there, just some very simple, reasonable expectations detailed. If they don't want to try it, they don't want to try it. But it should be part of this kind of for all presbyopes. Listen, you have glasses, contacts, surgical. I can tell you that this increases our surgical volumes when we do a lot of promotion for presbyopia drops. And number two, the practices that tend to prescribe a lot of presbyopia correcting drops like Qlosi, they end up selling a lot more eyewear, because the peculiar thing about this is when you use these presbyopia drops, you get good depth of focus and you understand what that is, and you get functional vision. But gosh, when you put on a really good pair of prescription readers, you say, wow, that is really good vision. And that's what I want when I'm sitting doing my taxes, or that's what I want when I'm sitting doing blah, blah, blah. So they understand the value of perfectly corrected near vision and the freedom of usable near vision, and they end up wanting both. And that's the way it should be realistically. And so that's the one thing, is it's not going to affect your business. If anything, it's going to help every part of your business, and it's going to make you seem like a leader in the community that's bringing innovation to the patients far before anyone else.
I am so much a partner with you on this. It is such a failure if a patient hears about something that you could do for them from a friend, from a television commercial, like whether you're going to prescribe it for them or not, make sure you presented it as an option. And if you don't feel like they're a good candidate, explain why that is. But you have to be the source of information and the expert that patient of yours is trusting when they have an eye care question. That is our goal, is to make sure we have offered and discussed everything available to them. And I know many doctors listening to the show feel exactly that same way and know that this conversation needs to be a part of their practice. Thank you so much for your time. I know we were talking earlier that we've got Academy coming up. There's a whole lot going on. Where can people follow along to learn more about you and your clinic, or see you speak in any upcoming meeting?
Most of them. At the Academy, I got the famed Saturday lectures. So when nobody's left, if you're still around at the Academy, come see me then. We could talk there. You can always also check out a lot of our vision enhancement, not just for presbyopia, but there is a ton of vision enhancement available for presbyopia. You can check more at sportsvisionpros.com and to learn everything that you need to know about this kind of stuff. But ideally, we're all in this for the same thing. We want better patient options. We want better patient care. And in an environment like this, we want to share our successes with others so others can have those successes with their patients as well. And that's what we're all in here for.
Before we sign off, tell me a little bit about your sports vision practice and how something like a Qlosi drop would fit into that. Because I think that's a very specific patient category that maybe we weren't thinking about.
It's the most. So I will tell you this, if you think about this, the interesting thing is everyone likes to come to the sports vision lectures because they want to hear me talk about this professional athlete or this team or the Longhorns that I work with, or, the Miami Dolphins, whoever, right? So, but 90% of the sports vision I do is on your weekend warriors, and people really can't afford to spend a lot of money on their recreation until they get in their late 30s, early 40s. And this is when presbyopia starts to hit them. So, this is a group that wants to stay active. They want to be active. They still want to go to the gym. They still want to play pickleball. They still want to do all these things. They don't want to be restricted. So these are the people that we end up dealing the most with. And I can tell you from targeting sports, whether it's archery, shooting, clay pigeons, birds, all that kind of stuff, whether it is the special forces guys I work with, or that are starting to age, or it's basically endless amounts of pickleball players. I can't tell you how much pickleball players like this, because the problem with any athletic performance is you can't constrict the pupil too much, because then you're going to really dim the peripheral world and you take away peripheral awareness, and you don't want to do that with an athlete. And Qlosi, I think, is a real sweet spot, especially with my pickleball players, because they love that they can wear a good pair of sunglasses. It doesn't affect their basically, ability to see the ball when they're playing pickleball. But then afterwards, when they're out with the ladies, they can still see the menu and they can get a drink afterwards. And so, it's just a quality of life thing that my active patients absolutely love. The golfers, especially, you sell them a good pair of wraparound sunglasses, then polarized or not, and then they can see their scorecard when they're golfing, and they can go and have dinner after golf. And so all these little things, huge benefit of life for these athletes.
We often overlook the athletes that are in our chairs, even, us eye doctors that aren't working with the sports team specifically. Many of our patients are golfing and playing pickleball, and they have these visual complaints, and the glasses solutions we have for them create so much issue for their sport. So think about, like you said, all of these athletes that are in your chair enjoying their recreational sports that could benefit from this. And if you've ever had to prescribe glasses for someone who does target shooting, you know how much this is going to benefit you. It's one of the most trying things to do as an eye doctor, is to they want to bring their gun into the office, and you're like, no, leave that at home, but we will try to simulate this. Thank you so much for reminding us about all of our athletes that we have in our chairs every day as just a regular eye doctor. If you guys want to learn more, absolutely check out your Qlosi rep. They're going to have a ton of information about how to best prescribe this, and more information about how to prescribe for your patients. And we can't wait to see you on the next episode. Thank you so much for your time. You can go to QlosiECP.com for more information.
All right, colleagues, and it's a wrap. Thank you dearly for hanging out with the Defocus Media team. We hope truly something resonated with you. And if it did, be sure to give us 5 stars. And make sure you follow us on all social media platforms: Facebook, Instagram, Twitter, LinkedIn, you named it. And our handle is at Defocus Media on all platforms. And until next time, be sure to keep it 2020. And we look forward to seeing you on the next episode. Indication and usage. Qlosi, pilocarpine hydrochloride ophthalmic solution. 0.4% for topical ophthalmic use, is a cholinergic receptor agonist indicated for the treatment of presbyopia in adults. Important safety information. Contraindications. Hypersensitivity. Warnings and precautions. Advise patients to not drive or operate machinery if vision is not clear. Example, blurred vision. Exercise caution in night driving and other hazardous occupations and poor illumination. Rare cases of retinal detachment have been reported with myotics. Examination of the retina is advised in all patients prior to initiation of therapy. Advise patients to seek immediate medical care when sudden onset of flashes of light, floaters, or vision loss. Qlosi is not recommended to be used when iritis is present. Qlosi should not be administered while wearing contact lenses. Remove lenses prior to installation of Qlosi and wait 10 minutes before reinsertion. Avoid touching the tip of the vial to the eye or any other surface. Adverse reactions. The most common adverse reactions, 5% to 8%, are installation site pain and headaches. Please see full prescribing information here. Qlosi.com/prescribing-information. Hey family, if you enjoyed this full podcast, don't miss out on more engaging content. Check out the next episode right here. And for the latest updates, hit that subscribe button and ring the notification bell. Your support means the world to us. Catch us in the next episode. Peace.